Thank you for the introduction, and thanks everybody for coming to Grand Rounds today. I'll be talking about caring for a child with autism spectrum disorder. So I have nothing to disclose, unfortunately. And objectives of this talk today is primarily to help all general pediatricians and also a lot of specialists in understanding the current epidemiology of autism and also the many different hypotheses of the etiology of autism that is currently out there. Also understanding the screening and diagnostic processes of autism, and also having a general feel and recognizing some of the common types of therapies that are available for children with autism spectrum disorder, as well as some of the more common comorbidities and how to approach them. Also, approaching some of the challenging and problem behaviors, how to approach that as a general pediatrician, as that is one of the main problems that cause distress in families who are caring for a child with autism. And also understand how to approach some of the many CAM therapies that are out there that families have access to. So the current epidemiology of autism, recently they did a survey, the National Survey of Children's Health conducted a survey with parent-reported autism that was found to be approximately 2% in school-aged children. And this, bear in mind, this is parent-reported autism. And the CDC actually recently did another study in 2012 with a more strict and accurate diagnostic testing of autism that estimated the prevalence to be about 1 in 68 children, which is 1.46% of children having autism. Just to put that in perspective, in the area that we are living in and we're caring for, the greater Tri-Cities, if we estimate it to be about 500,000 people, and we calculate that to be about 100,000 children in this area, there's more than 1,000 children with autism spectrum disorder that we are serving here, if the epidemiology is correct. So definitely there's a very high prevalence of autism currently. The male to female ratio is known to be about 4:1, and it's much more prevalent in males. But when a female is diagnosed with autism, they tend to have a more severe intellectual disability. And the autism spectrum disorder has tremendous healthcare costs involved with it, and it's estimated to be about $11 to $60 billion a year, and that was only back in 2011. It could probably be higher now. And that incorporates all the direct and indirect costs, such as medical care and special education costs, and also taking into account for lost parental productivity. So the burden is definitely huge. The reasons for the recent increasing diagnosis of ASD is likely due to diagnostic substitution, which means basically children that were previously identified as maybe just learning disabilities or speech delays or ADHD are, with more stricter screening and better diagnostic criteria, are now being incorporated into the big umbrella of autism spectrum disorder. And also the broadening definition of ASD, which we'll touch briefly on later with the DSM-5 criteria. And also with just better screening and ascertainment, with better training, we are identifying more children with autism spectrum disorder, which means us as providers and pediatricians, we have gotten much better in recognizing and treating children with autism spectrum disorder, which also means more children who have autism spectrum disorder who would have gone undiagnosed and just grown up not being labeled with any kind of diagnosis are now able to receive appropriate interventions, which is very important because if we think about autism spectrum disorder, it is a disorder that causes a lot of social interaction problems, and somebody who might be a high-functioning autism spectrum disorder patient, not knowing that diagnosis, they might have been labeled their entire life as that weird guy or weird kid who never makes appropriate social interactions. But with that diagnosis, there's a better level of understanding of that person's deficits. So that has helped a lot in the children with autism spectrum disorder. But still, the problem is that the average age of diagnosis of autism still remains at 4.5 years of age, which is still much higher than we would like because a lot of interventions can be started prior to being 2 years old. And the earlier you start the interventions, the better the prognosis. So what are some of the etiologies out there? Obviously, we've talked extensively about how the theory about vaccinations, MMR vaccine, can cause autism, which definitely has been debunked. But still, there's a lot of thoughts out there that parents believe that MMR vaccine could cause autism. Also thimerosal, which have been extensively discussed, which is the mercury-containing preservative in the previously used multi-dose vaccines. But the hypothesis that thimerosal could even cause, or mercury could even cause autism has been debunked. And also the fact that thimerosal is not used anymore in vaccines gives us more information to push for those vaccines. And in the event that parents still refuse vaccines, the AAP has a recommended refusal to vaccinate form that AAP recommends us to get the parents to fill out in the event that they still refuse. Some other etiologies hypothesis that's out there is neurobiologic factors. The main idea behind it is that about a quarter of the patients with autism spectrum disorder tend to have EEG abnormalities. Not always correlating with seizures, but a lot of them do have these abnormalities. And also they have had abnormalities that shown up in the MRI or diffusion imaging studies, and that leads us to wonder if there is definitely some sort of neurobiologic factor that predisposes kids to autism. There's also some reported studies that have noted elevation of peripheral serotonin levels in children with autism. There's also genetic factors that could play into autism. Studies have shown that the risk of a sibling of a child with autism, of having autism, is approximately 18.7%, which is much higher than the general population of approximately 1.5%. And they have identified multiple genes that could be causing or is associated with autism in multiple chromosomes. And also we have identified many associated certain genetic disorders such as Fragile X, neurofibromatosis, and also tuberous sclerosis. Also some diseases like Rett syndrome or Angelman syndrome have been associated. But nonetheless, 75% of the children with autism don't tend to have any measurable genetic abnormalities. So genetic factors can definitely not be the only driving factor. And this is a table I stole from an article in Pediatrics in Review that goes over some of the common syndromes associated with autism. Tuberous sclerosis, neurofibromatosis, Angelman syndrome, Fragile X, and Rett syndrome. You can note that all of these syndromes have at least a quarter to half of their patient population being diagnosed with autism. So there's a very strong correlation. And when we suspect a kid with autism, we could definitely take that into account and make sure that we rule these out too. There are also a bunch of other hypotheses out there that could it be an immune system related issue? Could it be related to hyperbilirubinemia and phototherapy? Also in uterine exposure to beta agonists, which they haven't been able to find any association yet. And also there have been questions about association with maternal obesity and maternal diabetes. All of these, there's just not enough evidence to support these hypotheses yet. There was also a study done to look at flu vaccine in pregnant women, if that was correlated with autism, and it was proved there was no statistical significance. Another study was done regarding aerial spraying to combat mosquitoes. This was an interesting study done in the state of New York. They divided into the patient population into zip codes, and the zip code that had, the only zip code that had the aerial spraying of the pesticide to eradicate the mosquitoes of Eastern equine encephalitis virus, found that specific zip code had a 25% higher chance of having autism spectrum disorder. And they noted that previously autism had been somewhat associated with pesticide exposure too, and they threw out the question whether the delivery method of pesticide could also affect the autism prevalence. That was an interesting study that was done in 2016, I think. But with all these hypotheses out there, there are some identified risk factors for ASD that we do know of, and those are closer spacing of pregnancies. When children are born close together, siblings, they have found that there is a slightly higher chance of having autism spectrum disorder. And obviously a sibling of a child with ASD, and also advanced maternal-paternal age, multiple gestations, extreme prematurity, less than 26 weeks gestational age, and also high-risk genetic disorders that we looked at earlier. So early recognition is extremely important, like we discussed earlier, because behavioral therapy can start as early as 18 months of age. And if you start earlier, you can definitely decrease core symptoms of ASD, and you can also improve cognition, language, adaptive skills, and some measures of social behavior. But the problem is that us as pediatricians in a study reported that we weren't delivering the adequate care due to low self-efficacy in meeting the medical needs of the children. And some of the reasons they cited as barriers to providing adequate care was just difficulty with care coordination and insufficient training in autism, and also poor reimbursement compared to the time that we have to invest in caring for these patients. So what are some of the early signs and symptoms that we can see in children with autism spectrum disorder? We can categorize into two big categories. The first being the impaired social communication and interaction. And you can subdivide them into different groups as well. First being the social reciprocity, which is the child not being able to be aware of another person's emotional perspective. So they don't understand why this person may be frustrated or sad or happy. They just don't have that social connection, and that is called social reciprocity. Also, impaired joint attention is one of the common things that we do learn about in autism, that the child has difficulty or is unable to point at things. But to be more specific, autistic kids can point at certain things, and you can divide finger pointing into two different types of finger pointing, and one being the proto-declarative and the other being proto-imperative pointing. The proto-imperative is something that an autistic child can do, and they are pointing primarily just as another method of trying to reach out to something. So they're not trying to point at something to point it out to somebody else, which is the mechanism of joint attention. They are not pointing at something and looking at somebody else to show that that is what they're trying to get at. They're merely pointing just in their effort to reach that specific object. So the fact that they are pointing at something does not automatically rule out autism spectrum disorder. If they are unable to use proto-declarative pointing, which is pointing with the purpose of trying to point that object out to somebody else and creating that joint attention between the object and another person, that is the key in terms of the patient not being able to point at something, which is a lack or impaired joint attention. Autistic children also show an impaired nonverbal communication. They are unable to use or interpret other nonverbal behaviors or gestures, facial expressions. That just does not mean anything to them, and they are also unable to utilize gestures and body language or facial expression. And they just have little or no interest in any kind of social interaction with other people. The other major criteria or subgroup of signs and symptoms is the restricted and repetitive behavior, interests, and activities. Mainly these are categorized as stereotyped behaviors, motor mannerisms such as hand flapping, rocking, twisting, toe walking. The terms that are commonly used in the Society of Families of Autism is stimming. They would like to call it stimming, that the patient likes to stim to express their emotions. Sometimes they do it just because they're happy. Sometimes they do it because they're frustrated. But it is a repetitive behavior. Also, the insistence on sameness. They have a hard time with transitions. Also, very restricted interests, especially in the older kids. You're able to note that the patients have a very restricted interest in weather or dates or schedules, phone numbers, license plates, Pokemon, specific cars, or whatever it may be. And they are very zoned into that one area. And sometimes that can result in a very a professional level of knowledge in that area. I remember growing up, thinking back, it was a kid who had autism, and we were living in a city of about 4 million people, so it was a big city and a lot of public transport, but he was just so focused and had very restricted interest in public transport. And he drew all the maps of every single public transport line in the city, buses and subway trains and everything, and he was just so focused on it. And you could just ask him, how do I get from point A to point B? And off the top of his head, he would say, you have to take bus number whatever, and transit to bus whatever at this point. And he was just a master of that. And that could happen with children with autism that have very restricted interests. Also, a very pronounced difficulty in sensory perception. A lot of autistic kids have sensory processing problems associated with their illnesses. So how do we screen for autism? Mainly, we know about the most commonly used MCHAT that we use in our clinic. It is recommended for an age group of 16 to 30 months of age. There are many other screening tools. This is a table that I took from Pediatrics in Review that recommend screening tools for different age groups. In an infant age, they recommend an infant and toddler checklist. And also for kids that are preschool and school-age children, childhood autism screening test called the CAST is also recommended. And these can be used to screen autism in children. The CDC and AAP published a surveillance and screening algorithm for autism. And if you follow the algorithm on the right-hand side, for any surveillance visit, which is a well-child visit, or any visit, any visit that is brought up with concern of autism, it is recommended to score any of the risk factors that the child might have of autism spectrum disorder, which is any sibling with ASD, any specific parental concerns, any other caregiver concerns, and if there's any pediatrician concerns with ASD. And depending on the level of risk, it is stratified into when you would use this screening tool and also when you would refer. And when you do make the decision to refer, it is important to make referrals to 3 different providers. First being the early intervention, and then the behavioral or developmental specialist that is going to evaluate for diagnosis of ASD, and also for an audiology referral so that they can get a hearing test to make sure it is not a speech delay caused by hearing problems. And those are the main referrals that you need to make once there is a strong suspicion. And you can always access this algorithm online called the autism alarm. So the diagnosis is made primarily by the developmental/behavioral pediatrician using many different tools that are available to them. But just to go over briefly about the DSM criteria, which was changed in 2013 to DSM-5, now excludes the Rett disorder, which is now eliminated because it's no longer considered the autism spectrum, but more of a genetic disorder. The 3 previous separate entities, such as Asperger's and pervasive developmental disorder and childhood disintegrative disorder, are all lumped into a big umbrella called the autism spectrum disorder. And also the symptom categories, which were previously 3, were clustered into 2 major symptom categories. And the basic 5 criteria that you need to meet in the DSM-5 criteria, there are more details under each criteria, but just to get a general idea, the patient needs to have persistent deficits in social communication, social interaction across multiple contexts. And also the patient needs to show restrictive and repetitive patterns of behavior, interests, or activities, like we discussed earlier. And symptoms must be present in early developmental period. And also it must cause significant clinical impairment. And these disturbances must not be explained by simple intellectual disability. And those are the criteria that we need to look at. And once they're diagnosed, we stratify them into different severity levels, level 1, 2, 3, and level 1 being the least severe, and typically would be the kid with high functioning autism spectrum disorder. And when we're suspecting autism, the initial workup and differential we have to include into our workup, which is a complete physical exam to make sure there's nothing that makes us worry about a genetic disorder that is going on, especially with the syndromes that we talked about earlier. We want to make sure the patient doesn't have any micro or macrocephaly, no cafe au lait spots or ash leaf spots. Also, you want to make sure there's no hearing problems that's causing the symptoms that we are looking at. And also potentially genetic testing to rule out any syndromes that could happen with autism. Screening for a lead level is also recommended, as that can cause cognitive delays. Also, neuroimaging and EEG has been talked about, but is not universally recommended screening test for autism, only when there is a high suspicion of a specific etiology or a comorbidity. And also metabolic testing can be something that you can think about as well. One other thing that we definitely have to consider is harsh psychosocial conditions that can mimic autism spectrum disorder. So children that are actually having PTSD or reactive attachment disorder or child abuse can sometimes present like autistic children that are socially dissociated, not interested in any social interactions, having speech delay. So this is also something that we do need to keep in the back of our minds when we're evaluating a kid for autism. So we would like to focus more on what kind of therapy options are there for autism and be familiar with them so we can guide the families to their decisions and options, also do our own part in research and understanding which therapies are better. So the primary goal of the intensive behavioral therapy is to minimize core features and associated deficits, such as all the maladaptive behaviors that could present in kids with autism, and also to maximize functional independence and the patient's quality of life, and also to alleviate family distress. There are many established behavioral and educational therapies, and we all know that medication has not been proven to show any kind of effect in treating autism. But there are many psychotropic medications that can be used in conjunction to maximize the behavioral therapies that we implement in autism, kids with autism. So this is the principles of effective early childhood intervention that is recommended in an article in Pediatrics in 2007. There are 8 points, 8 principles that they recommend to follow when choosing an intensive behavioral therapy. First is being early intro into intervention. As soon as the diagnosis is even considered, they recommend not waiting until we make the diagnosis of autism. As soon as we have any suspicion, to get the patient referred and enrolled into some kind of behavioral therapy, because the earlier you start, the better the prognosis. Also, the provision for intensive intervention. They want at least 25 hours a week throughout the year, and up to, they actually recommend 40 hours a week of intensive intervention. They also want a low student to teacher ratio, so you can get a lot of one-on-one time, including the family into the therapy, because the family will be spending 24/7 with the children, and they will be carrying on all the ideas and the therapy strategies at home. They also recommend creating opportunities for interaction with typically developing peers, so they have that exposure to the normal kids, and they have the chance to interact and learn from them too. And also to continue to have an ongoing measurement and documentation of individual child's progress, so that when they notice progress and when they notice changes, they can always make changes to their therapy strategies. Also a high degree of structure, because these kids are very adverse to change. They like routines and schedules, so to comply with that, to have that structure in the therapy. And also to try to implement generalization of the skills that they've learned. If they've learned how to cope with social anxiety or any stress being in a certain environment, when they are taught these coping skills, to actually take those coping skills and try to generalize it in those environments. So the first therapy, we all know about the ABA therapy, Applied Behavior Analysis, which is currently the most evidence-based behavioral therapy that is currently used for autism. It has shown repeatedly in randomized controlled trials that there is a definite effect of this therapy, and the way it can prove that too is just the way that this therapy is designed is designed in a way that it demonstrates which specific intervention was able to bring out this improvement in the specific behavior. So the way it's designed is very helpful in showing evidence that this is an effective therapy. And it is very useful in increasing and maintaining desirable behaviors, and also reducing interfering behaviors, and also teaching new skills and generalizing these skills in new environments and situations. And the long-term studies have also shown substantial gains in IQ, language, academic performance, and adaptive behaviors, and also some social behaviors as well. There are other types of behaviors that are out there, speech and language therapy, which should always go hand in hand with ABA therapy, primarily because regardless of how good of a speech the autistic child might show, the patient with autism would always have some level of deficit in social communication. And even though they might seem totally articulate, it is always recommended to refer them to social speech therapy and not exclude them from those opportunities. Also, for nonverbal children, they recommend the use of alternative communication modalities, such as the picture exchange communication system, which is used a lot. This is an example of the picture exchange communication, that the child can pick out certain pictures to use to express what they want to express if they are nonverbal. And this has shown to be very effective in nonverbal children. And some patients have even very expensive iPad applications that they can download for a cost that has tons and tons of pictures, pretty much all the words that you can pretty much think of that a child would need to express themselves. One might wonder if that is detrimental to the child's eagerness to learn actual speech, but some studies have shown that introducing alternative communication modalities to a nonverbal child might actually stimulate them to learn vocal speech. So this is also another modality that you should consider, primarily on those reasons too. Structured teaching is used in a lot of settings. There's just not much evidence in controlled studies. Developmental models, such as the Denver model and the relationship development intervention, the RDI, is also more kind of a play therapy, also focusing on specific deficits. But these studies, even though they've shown some improvement, the studies just lacked good controlled trials to support their evidence. Social skills instruction is a therapy that can be used to teach skills of joint attention, something that we talked about earlier, paying attention to two things at the same time, and also symbolic play skills. The thought is that this can be taught, and if they are taught at an earlier age, it has significant benefits in social interactions, and it can be generalized to different settings and people. There's still not a lot of evidence and studies that has been conducted on this specific therapy. And OT and sensory integration therapy is also used generally a lot, but there's still a lot of evidence that's lacking for efficacy, and specifically for children with ASD. So we'll talk about some of the common comorbidities that we need to deal with as general pediatricians caring for autistic children. The first one being seizures. The population of autism spectrum disorder tend to have a much higher prevalence of seizures, and it tends to be even higher if they have a severe global developmental delay or mental retardation. And if you are high functioning, typically the high functioning kids tend to have a lower prevalence, somewhere in the 5 to 10% range. And there tends to be a bimodal onset, first being in preschool years before 5 years of age, and then in adolescence. Like we talked about earlier, the EEG findings on autistic kids tend to show a lot of abnormalities, but there's just no evidence to treat those abnormal EEGs if they're clinically asymptomatic. So they don't recommend universal screening with EEGs in a workup of children with autism spectrum disorder. GI problems is also a very common problem that occurs in children with autism. In a survey that was done in 2006, they found that during the lifetime of the children with ASD, they reported about 70% of them that had abnormal stool patterns, constipation, vomiting, or abdominal pain at some point during their life, which was significant compared to other groups such as just other developmental disabilities had only 42%, and other normal children had 28%. Also, they had much higher evidence of radiographic constipation in ASD children, with 36% compared to the normal population, control population, which had 10%. Autistic children are very well known to be picky eaters, and there has been concerns about malnutrition, but a lot of studies have shown that there isn't that significant of a problem of malnutrition in kids, despite their significant dietary selectivity. And they don't really recommend specialized GI testing when they're asymptomatic. Sleep disturbance is also another common comorbidity, very common in almost all autistic children, but there's not a good randomized double-blind placebo-controlled study to support any kind of specific intervention or management for this. But some evidence has shown that children with autism tend to have an abnormal melatonin regulation during nighttime. One of the studies showing almost less than half of the level of melatonin in children with autism compared to control populations, and they have shown a good anecdotal evidence that melatonin really helps in sleep aid, sleep initiation especially. And they're also trying out new medications called ramulteon, which is just a high affinity melatonin receptor agonist, and has shown to be quite effective in children and adults with sleep problems in autism spectrum disorders. Another problem that they frequently have is anxiety and phobias, which can be screened with many different types of screening tools, like the Spence Children's Anxiety Scale, and also the Scared screening tool. But they say medication is very rarely needed in autism kids with anxiety or phobias, and just behavioral therapy is typically enough. OCD is also very common. It's the second most common co-occurring condition in ASD, and more than a third of them have some form of social limitation because of OCD. And the early signs are a very strong unwillingness to change routines, and that can be identified. And SSRIs are very frequently used to treat OCDs in autistic kids, but the Cochrane review in 2010 showed no evidence of effect for SSRIs for OCD or anxiety, which is quite interesting. But there's still a lot of anecdotal evidence that people kind of cling to and still use that for OCDs. ADHD is one of the most common comorbidities. 2/3 of children with autism have ADHD. For some reason, they tend to be much more sensitive to the medications, and they tend to have more adverse effects and irritability at even lower doses. So the common recommendation is to start low and go slow with ADHD meds for autistic kids. Depression is also very common, and it's a big problem in children with autism, especially as they get older and they become more aware of their diagnosis and their surroundings. Once they enter into middle school age, they tend to get teased and taunted, bullied at school. Especially it is a more frequent problem in high-functioning kids with autism that are actually exposed to just normal school environments, but are still socially awkward. And they suffer a lot from depression, and it is strongly recommended to screen all those kids with autism for depression with PSC 17 or 35 or PHQ-9s to make sure that they're not having symptoms of depression. Other comorbidities are intellectual disability, not always present. Some autistic children have normal IQs or maybe even high IQs, but this is also very commonly found. Irritability and disruptive behaviors that we'll talk about a little bit later, and also some kids with bipolar disorder or schizophrenia, some form of psychosis associated with autism. So how can we treat these psychosis or irritability issues? There was a great article that was published in 2016 called Irritability and Problem Behavior in Autism Spectrum Disorder. And it presented a good practice pathway for general pediatricians. And this is an algorithm that I took from it. And if you follow from number one, any patient that has a diagnosis of autism and presents to your clinic with concerns about significant irritability or problematic behavior, the first thing you want to do is assess for their safety. Make sure that that behavior is not causing any safety issues. If it is causing safety issues, you have to refer them directly to a higher level of care, such as a child psychiatrist who will use psychotropic medications. If there is no safety issues, you want to review the patient's full history and level of functioning prior to and after the onset of these symptoms to make sure if there's any other medical problems that could contribute to this. Once you have identified which specific behaviors it is, you want to prioritize which specific behavior you want to treat first. And you want to screen for any contributors to this specific behavior. And I guess the algorithm's a little too small. But if you follow from the left, sorry, is it okay? Okay. So if you follow from the left, you want to assess and address any current medical problems. If there's any constipation or any medical issues that might cause a child to be more irritable, you want to address that first. And then you want to address and assess any difficulties using functional communication. Like we discussed earlier, they have difficulties with social communication. Some kids are nonverbal. And when they have trouble communicating what they're feeling and what they want, that frustration could lead to a lot of irritability and problematic behaviors, and you want to screen that out too. And then you want to assess for any psychosocial stressors in the environment, and then also assess for any maladaptive reinforcement patterns in his environment, if the parents or teachers reinforcing these behaviors. And then lastly, you want to screen for any co-occurring psychiatric disorders like bipolar or anything like that. And then once those all those causes or contributors have been screened, then you can address the issues and follow up every 3 months to see if there's any improvement. And this is just a nice checklist form of the same algorithm that you can get from that article that you can use to screen for those. And this is a nice little booklet, a toolkit booklet that you can find online through ATN, which is the Autism Treatment Network, called Should My Child Take Medicine for Challenging Behavior? And this is more for the family that you can hand out. It's about a 21-page little booklet that they can read through when they're considering medicating their child for their problematic behaviors. And one of the examples of the pages is a nice little checklist that the parent can use to see which behaviors are causing significant distress and problems. And that could help them recognize if that behavior would benefit from medication or not. And that this could help alleviate some of the questions that the parents might have, or insistence on medicating or insistence on not medicating the patient. So some of the different types of medications that you could utilize for children with autism. This is a table from the American Academy of Child and Adolescent Psychiatry. They published a paper regarding their recommendations for treating children with autism spectrum disorders. And a lot of the medications are ones that we do recognize here and there. And we are familiar with clonidine and guanfacine, which are alpha-2 agonists that are very useful for irritability, and clonidine can also be used for sleep regulation when they are having insomnias and such. One thing that we need to realize when we are dealing with children who are on these medications, especially clonidine, is hypertension that we all are aware about. Some of the common antipsychotics that are used, aripiprazole, which is Abilify, is a medicine that is very much liked by child psychiatrists and has shown good effect in controlling problematic hyperactivity or irritability, and also a lot of those stereotypies, repetitive movements and such. Haloperidol is a medication that was used a lot back in the days but has kind of fallen out of favor, mainly because of the extrapyramidal symptoms that occurred in more than 25% of the patients that was tried on. And Risperdal is also another medication that a lot of pediatric psychiatrists would like to use. But one of the main side effects here is also increased appetite and weight gain in autistic children who have a lot of trouble regulating their eating habits. This could also pose some problems. Another group of medications, the mood stabilizers that have been tried, but a lot of the studies good studies, randomized control trials, did not really show great benefit from these mood stabilizers in terms of irritability and hyperactivity type of problems. An SNRI called atomoxetine, we're familiar with Strattera, is a medication that is commonly used for a lot of hyperactivity issues and has shown good response in children with autism. So for autistic kids who also have a co-occurring ADHD, Strattera might be a very good option. Some SSRIs that have been tried, especially fluoxetine, that is commonly used. It has shown it was not very useful in OCD and anxiety type of symptoms, but it has shown to be useful in repetitive behaviors. And also, like I said earlier, there's some benefit. There's some evidence anecdotally that SSRIs can kind of take off the edge in the irritable child and make them and less anxious as well. A lot of stimulants have been tested and tried in children with autism, and methylphenidate is the medication that has been studied most in autistic children and has shown great benefit in treating ADHD in children with autism. And some of the other medications that are not very commonly used at this point. So the last thing I'd like to discuss is the CAM therapies. Managing autism, children with autism, always comes with discussion about CAM therapies with the families. CAM therapy is defined by the National Center of Complementary and Alternative Medicine as a group of diverse medical and healthcare systems, practices, and products that are not presently considered to be part of conventional medicine. And the Cochrane collaboration defines it as a broad domain of healing resources that encompasses all health systems, modalities, and practices, and their accompanying theories and beliefs, other than those intrinsic to the politically dominant health systems of a particular society or culture in a given historical period. So basically what it means is just not the common medical approach that we have. There any complementary or alternative medicine out there can be kind of classified as a CAM therapy. And families with children with autism are always exposed to many different types of CAM therapies. And I think it is extremely important for us as general pediatricians to be familiar with some of the common CAM therapies so that we are able to have that discussion with the family and guide them in their treatment options and their decisions. A study in 2003, a survey, these are all survey studies, showed that almost a third of children had already received some form of CAM therapy before they even were evaluated for a formal evaluation of autism. So parents are very proactive in looking for CAM therapies. And another survey in a private practice population that was predominantly white, middle to upper socioeconomic status, showed 92% of parents had used CAM therapies for their children with autism. And 52% of children with all children with autism had been treated with at least one CAM therapy. And one of the surprising things was that all children who were being treated with CAM therapies, out of all of those children, only half of them reported to the primary care provider. So when we're dealing with children with autism, a lot of them are receiving CAM therapies without us even realizing that they're receiving these therapies. So it is important for us to recognize that these exist and we engage those conversations. So the Pediatric in Review article recommends an approach that divides the CAM therapies into 4 different groups. To divide it into safe and effective that have been proven to be effective, and those are the therapies that we should be recommending. And any therapies that don't show any known effect, but at least we know they're safe, we could tolerate those and let the parents try to experiment. But if there are any safety concerns, but there seems to be some effect, we need to monitor closely and obviously advise against anything that is unknown in terms of safety or effect. Most CAM therapies actually fall under the tolerate criteria, where it's mostly safe, but the effect is unknown. But some are in the other criteria that we need to be aware of. These are the major big groups of CAM therapy. One is non-biological, and the other being biological. Some of them are kind of strange too, like immunoregulatory interventions like IVIG therapy, antiviral agents. Some GI treatments like PO vancomycin or antifungals are also tried with the hypothesis that this is an immunomodulatory hypothesis that it might help. And a lot of dietary supplements have been tried. But not a lot of scientific evidence exists for most of the CAM therapies that are being tried out there. I'll just cover briefly some of the common ones. Facilitated communication is a therapy that is used to help the autistic child communicate through a facilitator, and a lot of study has shown that there's no evidence to support that. Actually, I was kind of amused that they reported that the communications produced actually originated from the facilitator and not the child with autism. Secretin therapy that received a lot of media a few years ago have shown that there was no effect in multiple double-blind RTCs that were tried. Also, IVIG therapy have been tried in many poor quality small studies, and the reviews were very mixed in that. Gluten and casein-free diet have been tried, but there's just not much evidence to support that or refute it. Omega-3 fatty acids have been tried. There was no statistical significance in the symptom scores, but within the study, they did note that there was some trend towards superiority over placebos specifically for hyperactivity. And they said this omega-3 therapy might warrant more investigation and could be potentially mildly beneficial. Chelation therapy is something that we definitely need to be aware of, because I have come across a patient which I had to talk about chelation therapy with the mom and advise against. It is based on the theory that there is a causal association between mercury and autism, but all the studies have not demonstrated that association. And even chelation therapy in patients that truly have chronic mercury toxicity have not shown any benefits in their nervous system symptoms. So treating these patients that are questionable at best in terms of even mercury exposure with chelation is not recommended, especially because there has been a reported death in a child with autism who was treated with chelation therapy with disodium EDTA back in early 2000. So this is definitely a therapy that we need to strongly recommend against, and we should not tolerate or monitor closely at all. Other therapies such as vitamin C, music therapy, trimethylglycine, and other supplements have been tried, and these three therapies have shown some mild anecdotal benefits, but still lacking in a lot of RTC trials and needs a lot more studies to be done. But definitely considered to be somewhat safe, and if a patient were to try to experiment with these, they could be monitored closely and see if there's any effect. So the main thing that us as pediatricians need to do is have a healthy discussion with the family about these CAM therapies. And the important thing is that we need to be aware and be sensitive about the family's needs or their emotional instability or their want for to just get that small edge to help at least improve their symptoms, even if it was a minimal gain. Parents are willing to try anything, and we need to be sensitive about that, and we definitely need to try to be not defensive or dismissing of the CAM therapies and maintain open communication, even if there's disagreement between the family and the physician. And one of the key things is to educate the families, because they'll always be researching and doing their own research about reading things about the therapy options out there, and we need to educate them how to recognize pseudoscience and how to critically evaluate good studies and evidence. Are they peer reviewed? Is the study population appropriately diagnosed? were they randomized, placebo-controlled, especially controlled for confounders. One of the big problems is they're not controlled for the natural history of the disorder. Autism spectrum disorder, the natural history of autism is going to show some improvement through the course of time. And when a study is not controlling for that factor, it just looks like the therapy or the intervention is doing the effect, but the patient is just developing at a reasonable or an expected rate of development in an autistic child. This is one little piece of information I came across reading Google. Thought it was interesting. Yes. I think it kind of goes a long way to kind of give us insight into what the parents actually feel. Sometimes we take it for granted that they're probably just used to having a kid with autism, but their level of stress is on a daily basis, and the social stress that comes with having a child with autism is tremendous, and we really need to be sensitive about that as general pediatricians. So the last thing is providing good family support. We have to recognize that parents play an extremely important key role in treating children with autism, because the behavioral therapy is an ongoing 24/7 process. And even though if we do intensive therapy for 40 hours a week, they're left with 80-something hours a week without the behavioral therapist to deal with this patient and to provide that structured environment and continue on with the therapies. And we need to recognize that, and also recognize that they have a very high stress lifestyle, the entire family, the siblings and the parents. And a study has shown that parents and siblings of children with autism experience more stress and depression, not only compared to the general population, but even compared to other chronic disorders and developmental disabilities, even compared to disorders such as cystic fibrosis that was compared in the study. The family had a much higher level of stress and depression with children with autism. And it is the role of the pediatrician to support and ensure emotional and physical health of the entire family that we're caring for, and also provide good anticipatory guidance and involve them in all the treatment strategies that we're selecting, and also provide good access to resources and support groups in the community, and also sometimes even take the step to refer the parents to adequate counseling or mental health services if we feel that they are having a lot of stress and showing signs of depression. These are some of the resources that I kind of utilized on the internet that is open to the public: Autism Speaks and Autism Treatment Network, ASD Hub, Autism Society. The information on autism open to the public is just very vast, and if you just type autism in Google, you'll come across a lot of communities and resources that you can utilize. And these are some of the references and articles that I used to prepare my talk. And thank you for your attention. I just added this picture to show a normal, typical developing child with adequate eye contact and nonverbal communication. So I'll take any questions if you have, or comments. Okay.
Thank you for a wonderful coverage of an extensive topic. Thank you.
Thank you. Thank you for your attention.